Thank you very much. And yes, I'm going to give you some examples and quickly and give some time for the discussion. I use the same slide, and I'd like to take this opportunity to thank Professor Pastor and Professor Romano to involve me in this project. And all the collaborators of the items group. You can see here, we'll go patient by patient. You can find the score that we published recently on the left, and on the side, the picture that we acquired in order to document. As you can see, this is a patient that we saw 1 month after the removal of heavy silicone oil. This means that whatever we are looking for, at least with regard to the anterior chamber, we are going to focus our attention on the inferior lower 1/3 of the anterior chamber, and we'll do other way around if we are in presence of conventional silicone oil. So we'll focus our attention in the upper third of the anterior chamber. You can see a tiny hypoleon, is called in this case, and some silicone oil microbubbles. There is, of course, some emulsification, some microbubbles at the level of the angle, in this case with an extension of more than 90 degrees, so with the highest score. At the Optos picture, you can see where there is that circle that there is some emulsification, some at the posterior pole, and the typical hyperreflective dots that you can see in this patient, both intraretinally at the level of the macula and at the disc. Going through the second patient, this is a patient where you can definitely see a significant emulsification. Interestingly, not so much in the anterior chamber, but definitely silicone oil microbubbles in the angle. And this is quite interesting if you focus on the fundus photograph, because you can see the difference on how the microbubbles appear when they are on the surface of the retina. If you look at the uppermost circle, and then on the other hand, you can see more distinct microbubble when you are just seeing the image of the microbubble floating after the removal of the silicone oil into the vitreous chamber. Obviously, this is something that you can do just when you are after the removal of silicone oil. Again, silicone oil associated hyperreflective dots within the retina and nothing at the level of the disc. So you can see the parameters, the score is always highlighted. We need just to do the sum and we'll have the final score. Another patient, in this case, we see quite a quiet condition. This is under silicone oil, a quiet condition in the anterior chamber, in the angle, looking at the retina. But actually we can see some epiretinal emulsion at the level of the fovea and within the optic disc excavation. Going to the next patient, again, some microbubble that we can see in the anterior chamber, nothing at the level of the angle. And again, you can see the difference between the microbubbles on the retinal surface and what you can see within the vitreous chamber. This is another example of hyperreflective dots. In this case, in particular, you can see also some other macro alteration that have been associated with the silicone oil emulsion that are the ERM and the macular edema, and again, the emulsification silicone oil related hyperreflective dots within the optic disc. In this other patient, obviously we are in presence of a massive emulsion. What we did in order to grade is to assume that obviously in presence of a such significant hyperoleon, we are in presence of the highest amount of emulsified microbubble in the anterior chamber, and the angle is involved at least for the extent of the hyperoleon. So we have the highest score in all these parameters. You can see a massive emulsion also at the level of the retina and intraretinally at the level of the macula. Sometimes it's happened also that emulsion cannot be detected, like in this patient. And this is interesting because be careful when you assess also the photo, now that we do so many virtual clinic, because all that artifacts are actually reflects from the silicone oil that are quite common, but they don't have to be confused with microbubble at the level of the retina surface. As Professor Romano anticipated, we are now going to do these multicentric prospective studies because now we have something that we can objectively use. So finally, we have something that can be validated from a clinical point of view and that can offer us a tool to compare the results of clinical study. Thank you.
Thank you, Maria Antonia. We have several questions from the audience, and we have approximately 10 minutes. So one of the question is, for me, is I have some patient that with silicone oil for 15 years without emulsification. As probably has been demonstrated, emulsification, you have to search properly before saying that you have not emulsification. Anyway, exception is a normal rule in medicine, and you can have patient without emulsification. There is a question for Kai, and the question for Kai is why you don't have on the rabbit cataracts, you perform a vitrectomy without gas.
Yes, as I was jokingly telling that before, it's because Martin and I operated the rabbits. No, but we think the buffering effect of the hydrogel actually had a positive effect on the cataract formation. Now, keeping in mind that, as I said before, every rabbit that you operate on the retina or when you just touch the eye develops a cataract. So this is very, very remarkable. And this is a very remarkable entity of the hydrophilic body. And I think it's because of this buffering effect.
Thank you. There is another question that can be, sorry.
I would like, Kai, we did these experiments together with Peter, with 3 of us, and actually we were surprised by the good results. However, I would like to be devil's advocate with this hydrophilic tamponades. Also, I'm very convinced from the approach that 2 things to be considered. We don't know how to remove it. If we need to remove it early, it will dissolve after a while, which is very positive, of course. But for example, if you have a PVR detachment and you have this hydrophilic tamponade in there, I have no clue how we could remove it. Or do you have a proposal how we could take it out if we need to take it out early to reoperate?
No idea yet.
And the second thing is all these protocols that have been described, I think they are off patent. So it's very hard to find a manufacturer to really go through to clinical studies and bringing something like this to the market. We were working together with manufacturers in the past, but they basically lost interest because no IP was possible because this cross-linking protocols have been reported in the literature for decades. Unfortunately, no manufacturer picked it up so far. I hope that one day they're going to pick it up because it's rather easy to sterilize like Helon and things like that.
Okay, thank you. Mario, there is another question, is there a difference in emulsification depending on the brands of the silicone?
So we measured the low molecular weight component concentration between different brands has been published. So there is a huge difference. So of course, this was measured in the lab. We assume that the low molecular weight component are also surfactants. Okay, so at least there are, this we can say for sure. Okay, we cannot say that the low molecular weight component means emulsification, but of course are surfactants that we are adding to the system.
Okay, next is for Salvador. I always use 1000 silicone oil because I did not find a big difference in emulsification rate compared with 5000. Obviously, it is difficult to inject and to remove the 5000 silicone oil.
Probably because you are removing the silicone oil, the low viscosity silicone oil in a short period of time. According to our meta-analysis, we didn't find differences between the silicone oil viscosity, But it is clear that higher viscosity, less dispersion, but the emulsification is a question or a matter of surfactants and not just the silicone oil viscosity.
Thank you. So there is a question for Martin. If a patient with AMD or diabetic macular edema in silicone oil-filled eye, and you have to inject antivascular endothelial growth factor, what do? You inject these drugs in the silicone oil-filled eye.
Well, the problem with anti-VEGF and any other hydrophilic drugs is that it will not dissolve in silicone oil. So I try to avoid to inject anything. If I really need to, I try to adjust the dose, although this is not really well calculated. I only try to give a quarter of the dose because I would be afraid of overdosing it. But however, if not absolutely needed, I would avoid injecting anything into silicone oil because it's so lipophilic that all our drugs are not going to dissolve in there. And that's what you should especially consider if you have endophthalmitis and you would like to treat with antibiotics, then you might easily overdose them.
Rosa, may you add some information about the same question, please?
Yes, if I have to inject, I would do it. I don't mind if there is silicone oil inside the eye.
Okay, thank you. There is a question that I can understand, honestly. I think the opacification of silicone is the manufacturer. Maybe the manufacturer is a nightmare for some of the question, but I don't know, manufacturers are opacified. What do you think about the opacification and the relation with the manufacturer? Probably they want to say that this is a problem related with the how they made the silicone oil. I don't know.
It's probably when we inject the silicone oil, we go through the cannula. So, I mean, we are going inside the cannula, and then, after, the cannula, goes, again in the structure that was before. So probably pushing through can be, some modification, but if you inject silicone oil, sometimes you see, some, clouding, yeah, and then they dissolve, but they dissolve then in the day after, you don't see any.
Maria Antonia, I think do you have a practical advice about how to differentiate bubble smaller or larger than 200 microns?
Yeah, it's not a casual cutoff. It's chosen because it's the minimal length, the minimal size that you can detect at the slit lamp. If you check on the slit lamp, there is the 0.2 that you can reduce the beam until 0.2.
And you are lucky because you have another one is using the gradient system, how to differ retinal high reflex with silicone oil bubble. That's the question.
Okay. I suppose that it refers to the silicone oil related hyperreflective dots are just hyperreflective dots of small size. When you see some silicone oil under the retina that you can detect at the OCT, you see it like an hyperreflective inclusion, and so it's very, very different because it appears black essentially on the OCT, completely hyperreflective.
And the last question for Mario is, did you compare the silicones from different companies?
This is the topic is very hot because they ask me the same
now the results, yeah.
So yes, and this is published.
Okay. So I think it's time. Thank you so much for being here, and I hope you have to learn a little bit more about emulsification. And please use the classification and the protocol. I think it's very important to unify the information. Thank you so much. Nice evening. ¿Podemos tomarnos una picture?